Dear doctors and caregivers, it is my utmost pleasure to introduce to you Dr. Ulhas Pandurangi, an esteemed expert in the field of cardiac electrophysiology and pacing. Dr. Ulhas currently serves as the Chief of the Cardiac Electrophysiology and Pacing Institute of Cardiovascular Diseases, Arrhythmia Heart Failure Academy of the Madras Medical Mission in Chennai. With his expertise, Dr. Ulhas Pandurangi has made significant contributions to the field of cardiovascular medicine and has been instrumental in advancing the understanding and management of various cardiac arrhythmias. As a Chief of Cardiac Electrophysiology at Madras Medical Mission, Dr. Pandurangi has been at the forefront of providing cutting-edge care to patients with cardiac arrhythmias. With his extensive experience and passion for teaching, Dr. Ulhas is an exceptional speaker who can effectively share his insights on the evaluation of sudden cardiac death on ambulatory ECG, which is also called Holter monitoring. His ability to convey complex concepts in a clear and concise manner will undoubtedly make this webinar a valuable learning experience for all the participants. Please join me in extending a warm welcome to Dr. Ulhas Pandurangi as he shares his invaluable insights with us today. Welcome, Dr. Ulhas Pandurangi.
Thank you, Suman. They were like more than just the kind words. Thank you very much. Thank you, Salman, from the G. Thank you, Shweta, for setting this up and all the members of the G. It's my privilege you have given me to speak to my colleague cardiologists, physicians, and other specialists. I'm told several attendees across the country are going to be attending this session. I think it is going to be an interesting session. I have my colleague, Dr. Amuthan, a renowned cardiologist, echocardiographer, and also interested in electrocardiology. I think I and him are going to share some of our wisdom, which we have earned over the period of 25, 30 years with you people. Let me share my screen. So I hope the screen is clear. Suman, are we okay with my screen?
Yeah, absolutely, sir. This is fine.
All right. So we all know the utility of the ambulatory ECG in the diagnosis of certain symptoms, typically of palpitations, giddiness, etc. But today we are going to be looking specifically at how ambulatory ECG is utilized in the evaluation of the risk of sudden cardiac death. We all worry about the sudden cardiac death, and ambulatory ECG, how it helps us to predict the occurrence of certain malignant arrhythmia. Before I proceed, a few words about sudden cardiac death, its definition. Sudden cardiac death is considered to have occurred if there was a death within 1 hour of onset of symptoms in the witnessed cases, and within the 24 hours of last being seen alive when it is unwitnessed, and the cause of the death is presumed to be of a cardiovascular etiology or on the basis of autopsy. Sudden cardiac death is certainly a major public health problem. 50% of all the cardiovascular deaths are sudden, and in quarter of the instances, sudden cardiac death is the presenting symptom. The person does not have any symptoms whatsoever, and he falls dead. And that occurs not less than about 25% of the times. The rough estimate of the incidence of sudden cardiac death in India is staggering. It's about 5 to 8 lakhs deaths per year. What is shocking and alarming is the sudden cardiac death typically affects the most active and productive age group, and that is between 20 to 50 years. That is what is bothersome, and this is what is a major problem. And today's discussion revolves around how do you prevent or how do you predict the sudden cardiac death occurrence in such young population with the help of ambulatory ECG. Elderly people are also are at risk for sudden cardiac death, especially if they have an underlying coronary artery disease. Let's look at some of the epidemiological aspects of sudden cardiac death. It is easy to identify without the use of the ambulatory ECG the risk for sudden cardiac death if you have your patients in clinics where they have symptoms suggestive of congestive heart failure, and typically when you do an echocardiogram, there's an ejection fraction less than 30%. These are the people are at the highest risk of sudden cardiac death, but it's easy to identify them. It is easy to identify another group, and that is the person who had already was fortunate enough to be surviving after developing a cardiac arrest because the CPR reached to him at an appropriate time. So there are patients whom we can identify. And we see that in the general population, if you see, or the population which is not as sick as this, if you see, these two groups have the highest number of sudden cardiac deaths in the community. The more number of healthy people in the society, less number of sick people are there in the society. And we should know that there's a large number of healthy, what we consider healthy people are at the risk of a sudden cardiac death. So that the maximum number, of course, it is in the general population, but it is just not practical. It is impractical to look at the risk factors in the general population. It's an enormous expense. It may not be cost effective. So at least we should be looking at some high risk subgroups, not necessarily very, very sick group. Who are these? Who are these at the risk for sudden cardiac death? Because they constitute such a huge number. And today's topic deals with how ambulatory ECG is going to detect this vulnerable population. There is a pressing need to identify the risk of sudden cardiac death in the high risk subgroups. So how the ambulatory ECG is going to detect these group of people who are at the risk of sudden cardiac death. Having discussed sudden cardiac death, its epidemiology, and who are, which number constitutes the major proportion, let's look at the difference between the standard ECG and an ambulatory ECG. Standard ECG is, we are very familiar with, it is an ECG which is obtained in a clinic or a lab. It provides a brief sample of cardiac electrical activity over 10 seconds. Ambulatory ECG monitoring provides the ECG data over an extended period of time, thereby permitting evaluation of dynamic and transient cardiac electrical phenomenon. It is much more than just the observation over 10 seconds. AECG, ambulatory ECG, comes also with a sophisticated analysis of the RR intervals. The intelligence that is associated with the AECG monitoring is much more than what you see in ordinary ECG machines. The intelligence incorporated in the AECG monitoring provides sophisticated analysis of the RR intervals, the morphology of all the waveforms, typically the QRS and T waves. It also looks at the late potentials, the QT intervals and its dispersion, the ST depressions, ST elevations over a period of time, and also the T wave alternance. So the interpretation that is obtained by the AECG monitoring is far superior than the standard ECG, and also it is based on a huge data obtained over a period of time and not just 10 seconds. So AECG can accurately and timely characterize any arrhythmia that is the patient is suffering, and because we know and we can characterize arrhythmia in a better way, we'll be able to treat our patients better. What is more important, this all comes not at the cost of discomfort to the patient, because the ambulatory ECG technology is non-invasive, it is easy to use, it is relatively inexpensive, and it is widely available. The credit of innovating this kind of a technology of monitoring the cardiac electrical activity for a long period of time goes to this gentleman seen on the screen, Norman Jeff Holter, and in his honor, this technology is also called Holter monitoring. Look at the initial technology. Jeff carried a huge load on his back, a big trunk on his back, which carried almost 50 kilograms, and this was connected telemetrically to the adjacent room. But at least he was not connected with the leads. His electrical activities were observed for a period of time, and this could be connected to an adjoining room. However, the modern AECG devices, as compared to Holter's original device, are extremely light. Nobody knows if you are wearing one AECG device. They're very inconspicuous, and this can provide, as I mentioned earlier, because of its intelligence, beat-to-beat ECG characteristics. And what is more important is, if there is an arrhythmia, it has the ability to alert either the patient or even the physician in real time by wireless transmission. Some ambulatory ECG devices also feature multiple biological signal sensors like respiratory rate, oxygen saturation, physical activity, temperature, etc. And hence, they provide more comprehensive information. So this is the typical ambulatory Holter monitoring, where it is almost like a necklace to him. Sometimes it could be placed even into the pocket, and depending upon the model, you can have, for example, there's a 5-channel, 3 channels, or almost like 12 channels, almost equivalent to the clinical ECG taken for a long period of time. This the information gathered is either retained here, or in the recent times, this is connected wirelessly to the physician clinic all the time. So even if the patient doesn't know the symptom, the physician who is observing this will get an alert, and then he can make an immediate diagnosis. And before this patient gets into any kind of a trouble or symptoms, he could be even called in. To make things more simple, the recent technology has enabled to get almost as much information from this particular device into a small patch here. It may not give as many leads information as the conventional Holter monitoring, but this would be very convenient to the patient, because with this, the patient can do all his normal activities, including taking bath. This is the most convenient midterm monitoring tool of electrical activity of the heart. Now there are devices, either dedicated mobile phone kind of a device, wherein the person can buy 2 electrodes and then wirelessly connected to this particular device, and a rhythm can be obtained. And recently, a mobile phone itself is converted into an ECG machine with a limited information. Anytime the patient has a symptom, either he can get this rhythm recorded on his own mobile phone, or a gadget called, this is called a live core gadget, where there is one device plus 2 electrodes. Whenever the patient has symptoms, he can press these 2 electrodes, and the device records the rhythm. Single lead may not be very accurately predicting the morphology, but at least the rhythm and the narrowness of the width of the QRS information can be sent to the physician. And of course, we are all aware about certain smartwatches. Shown here is an Apple Watch. I think it's the fourth series and forward. It can give you the information about the the rhythm, the rate, and almost reliable QRS morphology. And the earlier version was looking at the tachogram, which was looking at the blood volume going across the wrist. So there are many, and now because all of them are um, having the ability to transfer the data over a period of time, maybe 24 hours to say 48 hours or to 72 hours, dispatch almost like 1 week or 2 weeks, this all the time, but brief. You cannot go on looking at the rhythm because it's very uncomfortable for the patient to be always having the electrodes connected to his body. So if you really want to have a prolonged monitoring of the heart rhythm, say beyond 3 weeks, 4 weeks, continuously, you have another option, and this is called an implantable loop recorder. This can go on giving the physician the information and even to the patient if he has certain malignant arrhythmia through a wireless technology. And this can give the information as long as for 3 years. This is because the limitation here is there's a battery inside and its longevity is about 3 years. So let's now look at when to recommend ambulatory ECG monitoring for detection of risk for sudden cardiac death specifically. Most often, ambulatory ECG monitoring is recommended for the evaluation of the palpitations. But now, how it can be used specifically for the detection of the risk for the sudden cardiac death. If there are symptoms which the physician think which could potentially lead to sudden cardiac death. For example, if the patient has palpitations, giddiness, and syncope, and he is also known case of a heart disease, mild or severe, in the presence of a heart disease, these symptoms are always a clue that these symptoms may not be benign. They may be actually the harbinger of sudden cardiac death. So in this case, most often an ambulatory ECG monitoring is recommended. Palpitations, giddiness, syncope in the absence of a known heart disease, but in case where the person's family history is suggestive of sudden cardiac death, ambulatory ECG needs to be recommended because ambulatory ECG can detect and even predict the occurrence of the malignant arrhythmia that could be responsible for sudden cardiac death. There is a caveat. The diagnostic yield is highly dependent on the frequency of the symptoms. If the patient is having frequent symptoms, for example, every day once or every day twice, well, you can have AECG monitoring of a conventional variety, for example, typical Holter monitoring for 24 to 40 hours. But if the symptoms are rare, they happen once in a month or once in 2 months. In that case, we may be requiring to be doing extended monitoring for several times, or maybe going in for implantable loop recorders, or if the person before developing a syncopal episode, if he has palpitations, etc., he can go for the devices such as the Alive Core ECG, which I discussed, or some smart watches which can record single lead rhythm strip. Infrequent symptoms are rarely reproduced 24 to 48 hours, and hence one should not recommend just a 24 hours Holter in those patients who just have once in a while symptoms. There are certain syndromes which can cause sudden cardiac death, and that is because of either there occurs some QRS morphology change, intermittent widening of the QRS, either because of certain pre-excitation or because the QT interval intermittently prolongs, or there occur shortening of the QT intervals, there occur the changes in the not only the RR intervals, the PR intervals, etc. See, for example, long QT syndrome, short QT syndromes, WPW syndromes, Brugada syndromes. These are the syndromes which can be which studied better in a case where you think the patient is at risk for sudden cardiac death. 48 to 72 hours and preferably a 1 week of extended Holter monitoring might help in detecting the benignness or the malignant nature of the syndrome. ARVC, HCM are the other conditions where there are typically the ventricular ectopics, non-sustained ventricular tachycardias, occurrence of an atrial fibrillation even in HCM, which might be detected by the AECG. What is important is over the last few years, there had been a significant improvement in the solid state digital technology, which is giving us a better signal quality. Earlier, the interpretation used to be very difficult because the data that used to come used to be mixed with large amount of an artifact. But now the technology has helped us to get better signal quality. And of course, the artificial intelligence incorporated into these systems have enabled to have an increased accuracy of arrhythmia interpretation. Ambulatory ECG to prevent sudden cardiac death could also be discussed under the heading of those patients who survive the myocardial infarction. Myocardial infarction survivors, they're lucky because 50% of them die suddenly without as a first symptom. But if they have a myocardial infarction, they get admitted, and if they survive, unfortunately, they're still at an increased risk of sudden cardiac death. If you look at the statistics, 1 year risk of malignant arrhythmia after a hospital discharge is almost like 5%. So we should be really following them up very keenly. Usually, ambulatory ECG monitoring is performed over a 24-hour period before the hospital discharge, typically for patients with low EF or a STOMI course. And if they pass this phase, well, you do not require to do ambulatory ECG on a regular basis. However, during the follow-up, if you see a survivor of myocardial infarction on your routine ECG, there are frequent PVCs. Then you get them in ambulatory ECG. And if they have 10 or more per hour, or if they have a multiform PVCs, or they have an NSVT, non-sustained ventricular tachycardia or sustained, well, they are at the risk of the sudden cardiac death, irrespective of their underlying ejection fraction. The person who is suspected to have a coronary insufficiency is also at the risk for sudden cardiac death. So you have evaluated the patient on a conventional coronary angiogram, but then it probably has got a borderline lesion or no significant lesion, but you really believe that there's a coronary insufficiency. In those patients also, there is a role for ambulatory ECG, and then the way you can identify the symptoms correlate actually with the coronary insufficiency is looking at the STT changes with the ambulatory ECG monitoring. There are certain markers which we get from the AECG. For example, heart rate variability, heart rate turbulence, QT variability and dynamics, which represent the autonomic nervous tone. By themselves, they may not be very useful, but in combination with the other clinical data, they are believed to be useful in assessing the risk for sudden cardiac death. Let's go over some examples here. For example, this one, there is a PVC here. On a surface ECG, you had a PVC. The etiology or the underlying structure, underlying heart disease could be anything. But the ambulatory ECG will tell you the benignness or the malignant nature of this PVC. For example, you observed him. Look at this morphology, predominantly negative vector, and look at this. They are different from this, and definitely they are different from this. So what the PVCs you thought on the clinical ECG as benign because the patient has no symptoms, and under the underlying echocardiogram, it's not really very alarming. But then, if you see more often on your surface ECG, maybe you had done a treadmill test where the PVC is increased in number, the obtaining ambulatory ECG in them is helpful. There are times when you are thinking there is patient had no symptoms at all, but he is at risk for developing a problem. For example, here, this is an atrial fibrillation fast ventricular rate. Consider this patient is an HCM. Well, the HCM patient who has had some symptoms suggestive of some arrhythmia, if you want to really look at that, you can prevent the occurrence of a stroke in this patient, or maybe HCM patients with such rapid ventricular rate they can develop even a ventricular tachycardia. So ambulatory ECG in those patients whom you suspect to have a risk for sudden cardiac death helps enormously to tailor your therapy. Same here, the patient has an occasional giddiness, 75 plus old year man. He just has occasional giddiness. You may investigate in whichever the way in a non-invasive format, but you have not found out basal ECG is normal. But looking at this information, what you got from ambulatory ECG, you believe that you should be doing an ambulatory ECG in an elderly patient who are supposedly to have a sick sinus disease. Who can have a sick sinus disease as a cause of their symptom. And this can lead to not necessarily a sudden cardiac death due to malignant arrhythmia. This kind of a pause may make the patient to fall, and there's a grievous injury, and that could be fatal. There's a drawback, as I was telling earlier, all the time, whatever the data that comes to you with whatever the interpretation from the inbuilt intelligence might be misleading. For example, here is the Holter trace. A friend of mine had investigated because he was very keen that this young man, 38-year-old man who had a family history of sudden cardiac arrest, family history of a brugada, gets this and he undergoes and correctly he recommends the event monitoring, and this is the very malignant form of a rhythm seen here. But if you look carefully, these are artifacts. So the event monitoring has an important limitation, and that could mislead the patient as well as the physician. The smart watches can mislead the patient, the person who is wearing it, and the interpretation of the data could be extremely misleading, and that has led to unnecessary investigations and unnecessary invasive therapies. So we are looking for the improvisation of this ambulatory ECG monitoring technology, and I think very soon we will have a very, very helping hand from the artificial intelligence, which is evolving in a very, very remarkable way. And the contribution of an artificial intelligence into our wisdom about the arrhythmia analysis would make ambulatory ECG much more effective and less vulnerable to artifacts. With this, I will end my talk. Thank you.
Thanks, Dr. Ulhas. There is one question from the participants. Post-MI patients will have higher risk of sudden cardiac death. So, what is the recommendation to have, how frequently the ambulatory ECG to be monitored, and what is the criteria to do this?
Okay. So post-MI patients, I think the gentleman had understood that they always remain at a higher risk for sudden cardiac death as compared to the general population. Unfortunately, ambulatory ECG has a limited role in finding out who is at risk because it can simply tell you the arrhythmia load. So you recommend an ambulatory ECG in a person who survived the cardiac arrest in two situations. One, in hospital, for example, he survived. Usually there are 24 hours. Anyway, the patient is monitored continuously. You extend their rhythm monitoring inside the hospital beyond the 24 hours, like almost up to the discharge. If the patient has had a stormy course, and then he is revived. If his ejection fraction is preserved, please let him not go without further extension of his rhythm, because these are the people are at a higher risk. So you monitor a post-MI survivor who survived a very stormy course, even in the presence of preserved LV function. So this is one group. Another group who get discharged, and then if they remain sick, ejection fraction is lower than 35%, anyway they're at a higher risk. Well, it is the physician discretion. Either he would go for a primary prevention of sudden cardiac death therapy, or he would like to go further assessment. In that case, it is like not very clear whether that would help. Ejection fraction less than 35% beyond a period of say 3 months or so, that person is at risk for sudden cardiac death. You may or may not do the event monitoring. However, there is one particular group where the ejection fraction is kind of a preserved. They either have a palpitations, they either have a pre-syncope, or they had actually had a syncope, or during the clinical evaluation, you see the missed beats on their pulse, or on an ECG, you see missed beats in the sense, in the form of a PVCs, etc. And on the clinical basis, if you see the PVCs, if they are frequent, and if you do certain other tests, if the PVCs become more often, well, they need to be looked at it. For example, I showed one particular trace. That is a typical post-MI patient, preserved ejection fraction, having symptoms of palpitations, on a routine ECG, frequent PVCs. You made him to walk on a treadmill, the PVCs increased. Now, to rule out whether he is at risk for sudden cardiac death, you do the event monitoring.
Yeah, thanks, Dr. Ulhas, for the clarification. I think we will not see any more questions. So we would like to thank you, Dr. Ulhas, on behalf of GE Healthcare and all the participants. I would like to express our heartfelt thanks for sharing your knowledge and expertise. We are grateful for the opportunity to learn from you and look forward for attending more of the educational sessions from you. Once again, thank you for an outstanding webinar on sudden cardiac death on ambulatory ECG.
Thank you.
Thank you, sir.
Thank you.
Let me take this opportunity to introduce Dr. V. Amuthan, an esteemed expert in the field of cardiology. Dr. Amuthan holds several notable positions. He is Honorable Professor at the Indian Medical Association's National Headquarters in New Delhi. He is also Emeritus Professor of Cardiology at the Tamil Nadu Dr. MGR Medical University, and a former professor and head of the Department of Cardiology at Madurai Medical College. Dr. Amuthan's illustrious career spans several decades, during which he has made significant contributions to the field of cardiology. His expertise lies in the diagnosis and management of cardiac diseases, including acute coronary syndrome, which is our today's topic, a critical condition that encompasses a range of cardiovascular emergencies, including heart attacks. In today's webinar, Dr. Amuthan will share his profound insights into the role of ECG in the evaluation of acute coronary syndrome. We are honored to have Dr. V. Amuthan with us today, and we look forward to an enlightening session. Please join me in extending a warm welcome to Dr. Amuthan. Welcome, Dr. Amuthan.
Thank you, Mr. Suman, and thank you, Dr. Ulhas and GE Healthcare, for having given me this opportunity to speak about my favorite topic, that is ECG in acute coronary syndrome. Shall I share my screen?
Yes, sir. Yes, please.
Just adjusting the screen. 1 minute. Is my screen seen fully?
Yeah, it is visible, sir. Yes.
Any adjustments you want, need? Yes, today's topic is acute coronary syndromes and ECG diagnosis. These are my designations which have been already elaborated. And acute coronary syndrome, the term, is applied to patients in whom there is suspicion of confirmation of acute myocardial ischemia or infarction. Non-ST elevation myocardial infarction, which is called as N-STEMI, and ST elevation myocardial infarction or STEMI, and unstable angina are the three traditional types of ACS. Now, definition of acute myocardial infarction in 2018, joint task force from the Society of Cardiology, European Society of Cardiology, American College of Cardiology, and American Heart Association defined MI, whether STEMI or non-STEMI, on the presence of acute myocardial injury detected by abnormal cardiac markers in the setting of evidence of acute myocardial ischemia. So this is about the anatomy of basic anatomy of the myocardium. You can see here the epicardial coronaries traversing, and this is the endocardium, and this is the subendocardial area. This is the myocardium. This is the epicardium. And this is the risk factors which all of us know: smoking, hypertension, dyslipidemia, diabetes, and obesity. All these factors result in the development of the atherothrombosis, which results in the occlusion of the artery and ischemia, and development of acute coronary syndrome, which results in the chest pain. So here, emergence of acute coronary syndrome, this is a normal coronary artery, this is a normal flow. And you see, with the development of the plaque, the coronary artery lesion develops, the plaque develops here. These lesions prone to disrupt due to the underlying inflammation in the lesion. So this disruption of the lesion results in the development of a complete occlusion, which is no flow, which results in ST elevation acute coronary syndrome, or partial occlusion, which results in reduced flow. And you can see here, this is an animation which shows the LDL particles which damage the endothelial fibers. And these are the particles which come and damage the endothelial layer of the coronary arteries. And that results in engulfing by the macrophages, development of the plaques, and that results in the fatty streak. Initially, the development of the fatty streak, you can see here, and then formation. This leads to building up and then forms the plaque. And this plaque, when it gets enlarged, you can see here, this plaque is getting enlarged by the deposit of the fatty particles. That results in the development of the total disruption and leakage of the material which is inside. And you can see that the material is getting disrupted, and that leads to the development of the acute coronary syndrome, or total obstruction, which results in myocardial infarction, ST elevation myocardial infarction, and partial occlusion results in the development of non-ST segment elevation infarction. So this is non-ST segment infarction, where there is mainly affection of the subendocardial area, which results in ST segment depression. The diagnostic criteria is all acute coronary syndromes without significant ST elevation, or classified as non-STEMI. In most cases, there are ST segment depressions and T-wave inversions. And in patients with the transmural ischemia or total obstruction, that leads to ST segment elevation and formation of the plaques. So this is the sequelae of non-ST segment elevation acute coronary syndrome. You have to do the troponins. If the troponins are elevated, then it is called as non-STEMI infarction. If they are not elevated, it is called as unstable angina. So this may go for Q waves. The non-STEMI may go for Q waves, then it is called as QMI, or it may not go for Q waves, then it is called as non-Q infarction. ST segment elevation STEMI and acute coronary syndrome leads to elevated troponins, and that leads to the formation of the Q waves, and QMI or non-Q waves, non-QMI. So this is the SC segment elevation, and this is the SC segment depression, and this is the T wave, which is inverted here. Now, SC segment elevation, these are the classical examples which I have shown you in the inferior leads. This is the non-STEMI, where there is only SC segment depression. And pathophysiology of the SC segment elevation, there are many theses. As you can know, this is the diastolic current of injury pattern, and this is a systolic current of injury pattern where there is a primary SC elevation. Here they say it's a primary TQ depression which results in elevation. So this is one of the controversies in the ST segment elevation. However, in acute coronary syndrome, the ECG remains the key test for the diagnosis, and you have to look at the duration of the ischemic episode, that is the acute versus evolving or chronic infarction, its extent, transmural versus non-transmural, its topography, anterior versus infraposterior lateral or right ventricular, or the presence of other underlying abnormalities like LBB, WPW syndrome or a pacemaker patterns, which we will see. So this is the pathophysiology of this SC segment elevation. And one another point which we have to, which has come in recent days, is myocardial infarction with the non-obstructive coronary arteries. Myocardial infarction with the non-obstructive coronary arteries, where suspected STEMI ECG shows evidence of STEMI, and you do the urgent angiography, which shows no coronary stenosis more than 50%. Then the diagnosis is MINOCA or myocardial infarction with the non-obstructive coronary arteries. So these are the diagnostic criteria for MINOCA, universal AMA criteria, non-obstructive coronary arteries on angiography, defined as no coronary artery stenosis more than 50% in any infarct-related artery. No clinically overt specific cause for acute presentation. And these are the various causes which may lead to the suspicion of MINOCA. And now coming to the ECG sequences in MI, this is anterior and lateral and inferior wall. And anterior myocardial infarction results from occlusion of the left anterior descending artery. Anterior infarction carries the worst prognosis of all infarctions. And a study comparing the outcomes from anterior and inferior STEMI and non-STEMI found that on average, patients with anterior MI had higher incidence of in-hospital mortality. In addition to anterior STEMI, other high-risk presentations are anterior ischemia due to left main coronary artery occlusion and Wellens syndrome. How to recognize anterior STEMI is SU segment elevation with QA formation, the precordial leads V1 to V6, and the high lateral leads, that is lead 1 AVL, and reciprocal SU depression in inferior leads. The patterns of anterior infarction, the septal leads V1 to V2, anterior leads V3 to V4, and lateral leads V5 to V6, then you can call them as a septal, anterior, anteroseptal, anterolateral, and extensive anterior and anterolateral MI. And three other important ECG patterns to be aware of is anterior inferior infarction due to occlusion of a wraparound LAD, that is a type 3 LAD, which wraps around and supplies the inferior portion. And left main coronary artery occlusion pattern, widespread XT depression with ST elevation in AVR more than V1, and Wellens syndrome, where there is a deep precordial T waves inversion with or biphasic T waves V2 to V3, indicating critical proximal LAD stenosis. This is a hyperacute anteroseptal STEMI, ST elevation in maximal in the anteroseptal leads of V1 to V4. Q waves are present in the septal leads V1 to V2, and there is also some septal ST segment elevation in lead 1 AVL and V5, and reciprocal ST depression in lead 3. There are hyperacute peaked T waves in V2 to V4. This is hyperacute anterior STEMI. There are hyperacute T waves V2 to V6, most marked in V2 to V3 with the loss of R wave height. The rhythm is sinus with first degree AV block. There are premature atrial complexes, beat 4 on the rhythm strip, which is shown here below. and multifocal ventricular ectopy, PVC, on 2 different types, indicating an irritable myocardium at risk. This is evolving anterior STEMI. There is progressive ST segment elevation and QA formation V2 to V5. ST elevation is now also present in lead 1 and AVL. There is some reciprocal ST depression in lead 3. This is an acute anterior STEMI. This patient needs urgent reperfusion. This is extensive anterolateral STEMI. ST elevation in V2 to V6, lead 1 and AVL. Reciprocal ST depression in lead 3 and AVL. This is extensive anterior STEMI, ST elevation in V1 to V6 plus lead 1 AVL, and minimal reciprocal ST depression in lead 3 and AVL. Q waves in V1 to V2, reduced R wave height, Q wave equivalent in V3 to V4. There is premature ventricular complex with the R on T phenomena at the end of the ECG. You can see that premature. And that is a risk for malignant ventricular arrhythmias. This is deep Q waves in V1 to V3 with markedly reduced R wave height in V4, residual ST elevation in V1 to V3, left ventricular aneurysm morphology. This is a prior anteroseptal infarction or lateral MI. And this is a tombstoning pattern, massive ST segment elevation. You can see here, massive ST segment elevation with the tombstone morphology is present throughout the precordial V1 to V6 and high lateral leads. This pattern is seen proximal LAD occlusion and indicates a large territory of infarction with poor LV ejection fraction and high likelihood of cardiogenic shock and death. And this is anterior inferior STEMI, ST elevation present throughout the precordial leads and also in inferior leads. There are hyperacute T waves, most prominent in V1 to V3. This pattern is suggestive of occlusion occurring in type 3 or wraparound LAD. That is one of the wraps around the cardiac apex to supply the inferior wall. And this is the site of LAD occlusion. You can detect by some of the ECG appearance. The proximal, this is the proximal LAD, and then you have got the mid LAD and the distal LAD. And the S1 or the first septal supplies the basal portion of the interventricular septum, including the bundle branches corresponding to leads AVR and V1. And D1 supplies high lateral, D1 or diagonal supplies the high lateral region of the heart, lead 1 and AVL. And the occlusion of the occlusion proximal to S1, signs of basal septal involvement, ST elevation in AVR, ST elevation in V1 more than 2.5, complete RBB, ST depression in V5. Occlusion proximal to D1, ST elevation with the QA formation in AVL, ST depression more than 1 mm in lead 2, 3 or AVF. Reciprocal ST in AVL. This is one of our cases which when I was there in Madurai Medical College as HOD, and you can see this is a patient with acute anterior wall infarction, extensive tombstoning pattern. You can see here, and lead 1 AVL, V2 to V6, and you can see that extensive ST segment elevation. This patient, you can see here there is a on angiogram. You can see the proximal LAD lesion. And this patient underwent the PTC at that time, and after complete revascularization, ST segment normalized. So this is a primary, one of the cases where we did the primary in that era, that is 2009 itself. Is a lateral STEMI. Clinical significance is lateral wall of the LV supplied with the branches of the left anterior descending artery and left circumflex arteries. Infarction of the lateral wall usually occurs as a part of large territory of infarction. Isolated lateral STEMIs are less common, but may be produced by occlusion of small branches of the arteries that supply the lateral wall. That is the first diagonal. And how to recognize a lateral STEMI is ST elevation leads 1 AVL, V5 to V6, reciprocal ST depression in inferior leads, and ST elevation primary localized leads, lead 1 and AVL is referred to as high lateral STEMI. This is one of the classical examples of high lateral STEMI. You can see here lead 1 and AVL ST segment elevation, high lateral STEMI. ST elevation is present in the high lateral leads. There is a reciprocal ST depression in the inferior leads. And this is the recent high lateral MI. There is subtle ST elevation in high lateral leads, lead 1 and AVL. There is pathological Q waves in AVL plus inverted T waves in both lead 1 and AVL. This pattern is diagnostic of a recent completed high lateral MI. This is anterolateral STEMI, ST elevation in present in anterior V2 to V4 and lateral leads. Hyperacute anterolateral MI, where there is a ST segment. There is early ST elevation with hyperacute T waves in anteroseptal leads V1 to V4. There is also subtle elevation in the high lateral leads, lead 1 and the AVL. This is infralateral STEMI. There is ST elevation in the inferior 2-3 AVF and lateral, that is lead 1 and inferior plus lateral. Infraposterolateral ST elevation is present in the inferior and lateral leads. ST depression is there in V1, V2, and V3. With the tall, broad R waves and upright T waves and R by S ratio more than 1 in V2. Concomitant posterior infarction. This is ST elevation in the AVR, whether it is left main occlusion, widespread horizontal ST depression in most of the leads, and ST elevation in AVR more than 1 mm. And ST elevation in AVR may be also seen in proximal LAD and severe triple vessel disease. And the mechanism of ST elevation in AVR is lead AVR is electrically opposite to the leads 1, 2, and AVL, and V4 to V6. Therefore, ST depression in these leads will produce reciprocal ST segment elevation in AVR. Lead AVR also directly records electrical activity from the right upper portion of the heart, including the right ventricular outflow tract and basal portion of the interventricular septum. Infarction in this area could theoretically produce ST segment elevation in AVR. And predictive value of ST elevation in AVR, more than 1 mm is indicative of proximal LAD or LMC lesion. AVR more than 1 mm predicts need for CABG. AVR more than V1 differentiate LMCA from proximal LAD occlusion. Absence of ST elevation in AVR almost entirely excludes a significant left main lesion. Magnitude of ST elevation in AVR is correlated with mortality in ACS patients. More than 0.5 is associated with a 4-fold increase in mortality. More than 1 mm is associated with a 6 to 7-fold increase in mortality. And more than 1.5 mm has been associated with mortalities ranging from 20 to 75%. This is a complete ostial occlusion of the left main coronary artery. You can see here gross ST segment elevation in AVR. And this is a proximal LAD occlusion. This is one of our recent cases where there is a ST elevation in AVR and V1 of similar magnitude. Widespread ST depression, you can see here. Widespread ST depression in V3 to V6, lead 1, 2, 3, and AVF. This is the echo of this patient showing the strain abnormality in the anterior and inferior area. And this is the ECG, coronary angiogram showing the tight lesion in the left anterior listening artery proximal. And this patient underwent the angioplasty with a complete revascularization. This is a post-PCI, comparing the post-PCI and basal and post-PCI. And inferior STEMI. Inferior STEMIs account for 40 to 50% of all myocardial infarction, generally have a more favorable prognosis than anterior myocardial infarction. Up to 40% of the patients with the inferior STEMI will have a concomitant right ventricular infarction. That is the most important point. And up to 20% of the patients with the inferior STEMI will develop significant bradycardia due to second-degree AV block. The ST elevation in 2-3 AVF and the progressive development of Q waves in these leads and reciprocal ST depression in the AV. Inferior STEMI can result from occlusion of all the 3 coronary arteries, which you must remember. The vast majority of the inferior STEMI are due to occlusion of the dominant right coronary artery. Less commonly, wraparound culprit vessel is a dominant left circumflex artery. So these are the 3 lesions which can produce the LAD, circumflex, as well as the RCA can produce the inferior infarction. This is inferior STEMI due to RC occlusion, where the ST elevation in lead 3 and the AVF is more than lead 2. Whereas in circumflex artery occlusion, the lead 2 ST elevation is more than lead 3. This is the inferior wall infarction with the tombstone pattern. And this is the posterior wall MI. It's a horizontal ST depression, tall, broad R waves, and upright T waves and dominant R waves in V2, and reciprocal elevation in the V7, V8. You can see here, this is the V7, V8, and V9 leads. If you record the ECG, that will show the ST segment elevation. And coming to RV infarct, a complete set of RV right-sided leads have to be recorded in all patients with the inferior wall MI. So, and the most important lead is V3R and V6R. The most useful lead is the V4R, which is obtained by placing the V4 electrode in the fifth right intercostal space in the mid-clavicular line. And RV infarction complicates up to 40% of the inferior STEMI. And patients with RV infarction are very preload sensitive due to poor RV contractility and can develop severe hypotension. And this hypotension is treated with fluid overload, and nitrates are contraindicated in these patients. ST elevation V1, the only standard ECG lead that looks directly at the right ventricle, ST elevation lead 3 more than lead 2. So these are the other points for RV infarct. This is a patient, 58-year-old patient, where you can see ST segment elevation in 2, 3 AVF. Also, there is ST elevation in V6R. This is a strain pattern in this patient having the inferior septum, inferior wall, and infralateral wall abnormalities. And this is the coronary angiogram, which shows the 99% occlusion in the RCA. And that patient was underwent the PCI, and this is the final result showing the complete revascularization. This is after revascularization, and this is a strain pattern after the revascularization. True posterior wall MI accompanies 15 to 20% of the STEMIs. Isolated posterior MI is less common, 3 to 11%. And now coming to one of the most important points, that is the STEMI and LBB. Concordant ST elevation more than 1 mm in one of the leads, and concordant ST depression more than 1 mm in one lead. Proportionally excessive discordant ST elevation more than one lead in anywhere more than 1 mm in ST elevation is defined by 25% of the depth of the preceding S wave. So this is the Sargosa criteria for diagnosis. You can see here. This is in patients with the LBB, we have MI in concordant ST segment elevation. In LBB, we are supposed to have a T wave inversion, whereas if there is a concordant ST segment elevation, this is called as more than 1 mm. And in V1 or V2, if there is more than 5 mm ST elevation, this also can be taken up. This is one of the important signs, olden days, Cabrera sign, prominent 0.05 second notching in the ascending limb of the S wave in lead V3 and V4. And this is Chapman sign, prominent notching in the ascending limb of the R wave in V5 or V6. You can see here. And this is a patient with the LBB showing the infarction. This is the most important thing is the V4 lead, which shows the ST segment elevation. And STEMI and RBB, most important point is when there is RBB in presence of ST elevation MI, you can see here, that gives a sinister prognosis, a bad prognosis. And you can see here the STEMI in RBB, the ST segment elevation. The lines mark the end of the QRS and beginning of the ST segment. In RBB, there should be no ST elevation, but here you see the ST segment elevation. That is how we diagnose STEMI in presence of this. So, association of RBB plus left anterior vesicular block gives more bad prognosis and mortality, and presence of RBB in the AMI mortality rate increases severe, and the pseudo-semi and true ST elevation can occur. That can be differentiated by looking at the trick is to find the end of the QRS. See, the lines mark the end of the QRS, and there is no ST segment elevation, and that tells you that it is not see that. That is a point, end of the QRS, and look at that. This is Whelan syndrome's pattern of inverted biphasic T waves in V2 to V3, presenting with ischemic chest pain that is highly specific for critical stenosis of the LAD. Patients may be pain-free by the time ECG is taken. And these are the typical two types. One is a symmetrically deeply inverted T waves, V2 and V3, biphasic T waves in V2 and V3, less common. So this is the Whelan's type A. You can see here Whelan's type A. These are deep inverted T waves, so typically called as coronary T waves. This is a type B Whelan syndrome, and it was described first by 1982 Professor J.J. Whelans. The significance of it is in a population that could otherwise be sent home from the emergency department is that stress testing as part of your further risk stratification, probably a bad idea in this group of patients. And this is a non-ST elevation MI. You can see here, there is only ST segment depression in this patient. And this is the strain pattern you can see here in this patient. And that tells you that the patient has LAD is normal, left coronary system. And this is the RCA. You can see here the prominent 99% lesion there, limit RCA. This patient underwent the revascularization. And this is another case where you can have a normal ECG in acute coronary syndrome, and 75-year-old male. You can see here both baseline and after exercise, there is no ST segment elevation, whereas the exercise stress echo picked up the lesion there post-stress, and this patient post-stress compared to the basal, and you can see here 99% lesion there in the LAD after the D1, that is a prominent D1, and this patient underwent the revascularization. After that, his ECG and echocardiogram settled. This is another patient, ECG with normal this thing, and this is a basal post-stress. You can see the strain abnormalities develop, and this post-stress, and this patient has a marked lesion in the RCA, underwent revascularization. And post-PCA is another group where this patient is had a LAD and OM1 PCI in 2020, had a redo PCI for instant renosis in 2021. And you can see the stress testing. Just 1 minute here, you can see the gross ST segment depression, and there was gross fall in the ejection fraction from 53% to in the post-stress, it became to 46, and this patient has been referred for further treatment. Now, gentlemen, thank you for your patient hearing, and it is coffee time. Thank you for your patient hearing.
Yeah, thanks, sir. There is one question from the participants.
Yes.
One is like, what are the current guidelines and recommendations for the management of ST elevation in ACS?
ST segment elevation in ACS. All of us agree that this has to be revascularized. Whether you have to do pharmacological revascularization using the latest drugs, or pharmaco-invasive, suppose you are away from the primary PCI centers by more than 6 hours times for transit time, you can go for pharmaco-invasive, where the patient can be taken up for pharmacological management with the thrombolytic agents, and then can be shifted to the primary PCI centers And if the patient can be shifted to a center where primary PCI can be done immediately, and with a door to needle time of less than 3 to 6 hours, that is the primary choice. I don't know about the policy in Madras Medical Mission. It all depends on their time. Time is muscle.
Amuthan, what you speak of golden words, absolutely, I respect what all you are recommending. Suman, if you want me to add to something what Dr. Amuthan, my dear friend, told.
Absolutely.
Amuthan, we should make all our ER physicians and the general physicians to take an oath. You know what is that oath? After 7 p.m., if somebody comes to the ER with the chest pain, you know what? They don't have to see the ECG. They have come after 7 p.m. To the ER with the chest pain. Amuthan, don't you think they should be held back? They should never be sent home with some, thinking that is a gastritis because somebody read the ECG is normal.
That all depends on the age. If it is a 20-year-old young lady, you want to admit that lady?
All right. You don't admit. I agree. What I meant was in the context of the coronary artery.
Yes. In the age group, coronary age group.
In the context of the coronary artery disease.
Yes.
Okay. Let's not dilute this concept here. What I'm trying to say is the clinical probability of a coronary artery disease is estimated just by the age, just by the risk factors that are associated. Okay, so that could be even for a 20-year-old lady. 20-year-old lady does not mean that she is out of the risk for the coronary artery disease.
Yes. When I was in PJ, I was called to see a young lady who has just given birth to a child.
Yes.
And ECG showed some key waves. So there was a call in midnight. Then I went and saw it was a Ipaka infarction.
So what I'm trying to tell is, during your time, 20-year-old females, you thought they do not have the risk factors. The generation is changing. So let's look at first the complaint, the time with which they came. For example, I think there should be an universal rule: 7 p.m., maybe 6 p.m. for somewhere else. What I'm trying to say is, if the person comes with the chest pain to the hospital, you should respect that. They are uncomfortable. Okay, don't go by just the ECG information. Look at the history.
Yes.
And, maybe 20, 25, 40 years, maybe you depend on the history. But beyond the age of, say, 35 or 40, that's very, kind of arbitrary. I wish there should be a rule. If anybody comes to the ER with the chest pain after 7 p.m., they need to be held till early in the morning.
Yes.
Irrespective of whatever the ECG changes are. Because every single day, we know patient had come, we were told gastritis it was, sir, now it is like this. So I think the message, out of this whole program is ECG is the greatest tool, but it has such severe limitations. We need to be, incorporating some more intelligence into the ECG machines. It should, no ECG comes out without some more information into that, because people look into that so-called computer-generated information on that ECG. Okay, especially is widely prevalent in the labs or in small PHCs. Computer said everything is all right, normal. No, see, the history is not incorporated. So the G should try to incorporate some more elements into the ECG machine. Very quick, some 5-6 questions, and then it should give a red alert. All your GE ECG machines should give alert. What is the time? When did the patient arrive? 7 p.m. Don't discharge.
Very good.
Very
good suggestion.
In the morning hours, feed in the details. Look into this. And it's a very easy thing to calculate. And Amuthan can develop a software for you. Yes.
Software, they are the GE or the people.
Yeah, but the clinical,
clinical insights required from the experts like you.
Required from you. Yeah. So thank you, Suman. Yeah. Okay.
Sure, sir. Amuthan, sir, it was very insightful. Especially, I was impressed the way you explained about the ST elevation, T wave changes, and the Q wave developments. One of the participants commented they liked it a lot. So, thank you so much for your session. And Ulhas, sir, it's been very interesting your interaction, and especially the takeaway after 7 p.m. Even one case happened in our family also, where we went and then we came back next day morning. It was reported to be a severe, massive attack, and then it was admitted. I can relate what exactly you're saying. Thanks for a great insight. And both of you, thanks a lot for your time. And this has been an incredibly informative session. Thank you so much, sir, both of you.
Suman and all.
Thank you, sir.
Thank you.
When are we meeting?
Bye.
Thank
See you in Kodaikanal.
Thank you. Great day, sir. Bye.